Hello, my name is Juan Carlos Vargas, and today's topic will be electrolyte and acid-base disturbances in patients with diabetes mellitus. Definition: the prevalence of diabetes is increasing rapidly. In type 2 diabetes now accounts for 20 to 50% of cases of new-onset diabetes in young people. Electrolyte disturbances are common in patients with diabetes and may be the result of an altered distribution of electrolytes related to hyperglycemia, induced osmotic fluid shifts or total body deficit brought about by osmotic diuresis. Complications from an organ injury to the therapies used in the management of diabetes may also contribute to electrolyte disturbances. In this review, we highlight the ways in which specific electrolytes may be influenced by dysregulations in glucose homeostasis.
When food is ingested, it travels along the digestive tract, where it is broken down into its component nutrients in order to be absorbed into the bloodstream. One such nutrient is glucose, a simple sugar. Glucose gets absorbed by the stomach and intestines and then enters the bloodstream. It travels through the circulation to all body cells. Once absorbed into the bloodstream, glucose circulates, causing the blood sugar level to rise. An increased level of blood sugar sends a signal to the pancreatic beta cells, which respond by secreting the hormone insulin into the circulation. Insulin is necessary for glucose to reach and be used by several important target tissues throughout the body. These include the liver, muscle, and adipose tissue. Insulin is necessary to keep blood glucose levels stable in the body. Glucose enters the cell through a process called facilitated diffusion.
Applications in medicine: hyperkalemic renal tubular acidosis, type 4 renal tubular acidosis, is a common condition among patients with diabetes and overt nephropathy. The disease is characterized by disturbances in nephron function, which lead to impaired renal excretion of hydrogen and potassium, and result in hyperkalemia and hyperchloremic normal gap acidosis. Type 4 renal tubular acidosis may be present even in patients with mild to moderate diabetic nephropathy, and the magnitude of hyperkalemia and acidosis can be disproportionately severe relative to the observed reduction in GFR. A deficiency in circulating levels of aldosterone or disease affecting the collecting duct may lead to type 4 renal tubular acidosis, which results in a defect in the distal secretion of hydrogen ions. In such cases, multiple alterations in the renin-angiotensin system effectively reduce the circulating levels or the activity of mineralocorticoids. Hyporenemic hypoaldosteronism and volume expansion occur in many patients with diabetes mellitus, although these conditions are generally thought to be caused by a reduced GFR in association with the development of diabetic nephropathy. Studies in animals show that the direct effect of insulin and receptors on the distal nephron decrease the activity of lysine-deficient protein kinase 4, or WANK4, which leads to pathophysiological changes similar to those seen in the syndrome of familial hyperkalemic hypertension.
Hi everyone, I'm Dr. Poonam Sharma, Resident Physician at Healthify Me. Today we are going to debunk some myths about diabetes. If you're overweight, you always develop type 2 diabetes. Being overweight or obese is always a risk factor for diabetes, but other risk factors like how much physical activity you get, diet, exercise, and family history play a role. Diabetes is caused by excess sugar. This is not exactly true. A diet high in calories from any source, be it refined carbs, trans and saturated fat or sugar, contributes to weight gain, and weight gain increases your risk for diabetes. Diabetic women cannot get pregnant. Not true. A diabetic women need to be very careful in monitoring their blood sugar levels. A successful pregnancy and having a healthy child without any complications is possible. People with diabetes cannot eat sweets and chocolates. If eaten with a healthy meal plan and combined with exercise, people with diabetes can have sweets and chocolates occasionally. Type 2 diabetes is reversible. Type 2 diabetes is not reversible but manageable with significant weight loss if you're overweight, combined with regular exercise, diet, and appropriate medications. For more guidance, reach out to us and try a premium plan today.
What actually happens when acid is introduced into the body? Well, buffers take care of it. What are buffers? Buffers act like sponges, taking up hydrogen ions when there's too much of them and releasing them when there's too little. The primary buffers in the body are bicarbonate, or HCO3-, hemoglobin, phosphate, and bone. 60% of buffering happens intracellularly, and 40% happens extracellularly. The primary buffer in the extracellular compartment is bicarbonate. Let's see what happens when acid is added into the body. Let's talk about metabolic acidoses. So in metabolic acidoses, there's an excess of hydrogen ions. And what happens to these hydrogen ions? They combine with bicarbonate in order to form carbonic acid. So as hydrogen ions increase, bicarbonate decreases. And what happens to carbonic acid? Well, that dissociates into water and carbon dioxide. And what happens to carbon dioxide? Well, carbon dioxide, as you might already know, is then eliminated and exhaled through the lungs. We can adjust carbon dioxide elimination through hyper and hypoventilation. For completeness' sake, it's important to understand that this equilibrium also works into the other direction. So when the patient is hypoventilating, carbon dioxide is accumulating and combines with water to form carbonic acid, which then dissociates into hydrogen ions and bicarb. So hydrogen ions will go up in hypoventilation and the pH will consequently drop. You'll learn more about this equilibrium and the association between the respiratory and the metabolic system in the upcoming modules.
Now, as far as electrolyte depleters, there are two main exit doors where electrolytes leave the body and go into the potty. So we use our nifty acronym VPPS: vomiting, pooing, peeing, and sweating. So let's start with vomiting. Now, we've all done it before, and well, your digestive tract, also called your GI tract, your stomach and intestines, have tons of electrolytes stored in them. So vomiting or diarrhea or excess stoma drainage, like with a colostomy, will drain your electrolytes very, very quickly. Peeing or urinating, or basically your urinary tract, from your kidneys, or fancier words for renals and nephrons, down to your bladder and out your urethra. Because guys, electrolytes are in the blood, and the blood is filtered by the kidneys, also called the washer machines of the body, that wash your blood kind of like a little car wash for your red blood cells. Lastly, we have sweating, like when in the gym or running to class or right before your last nursing exam. Wait, what? We never covered this in class? I should have been an Instagram model. Sodium, also called salt, comes out during the sweating process. It's also called insensible losses. This happens big time with patients with heat exhaustion, fever from sepsis, or a process called diaphoresis, also known as profuse sweating. Basically, big time serious sweating. Lastly, a little side note, even burn patients lose a lot of fluid and electrolytes together in the same kind of process of fluid loss. So the big takeaway point here to wrap all this up is to remember electrolytes reside in fluid, because where fluids flow, electrolytes go. So let's critically think here. Let's say you threw up from having a bad burrito. Or let's say you're running a marathon, using your muscles vigorously and sweating way too much. Or you went to brunch because you passed your final exam and you ordered one too many mimosas or Bloody Marys or martinis and ended up urinating a lot because, let's face it, alcohol is a diuretic which makes you pee. Or let's say if you have massive diarrhea from food poisoning.
Ooh, you nasty.
Well, you're probably going to feel very, very weak and probably start having headaches, feeling lethargic or fatigued because your muscles are now weak, and now you're beginning to experience the signs and symptoms of an electrolyte imbalance.
Pros and cons. Randomized trials of phosphate therapy in patients with ketoacidosis have not shown that this therapy provides clinical benefit. Therefore, routine administration of phosphate is not recommended. In patients at risk for potential complications of hypophosphatemia, such as weakness in the heart of skeletal muscles, rhabdomyolysis, or hemolytic anemia, potassium phosphate can be added to replacement fluids. Of course, hypocalcemia and hypomagnesemia are potential complications of phosphate administration. Conclusion. In summary, the dysregulation of glucose homeostasis leads to many direct and indirect effects on the electrolyte and acid-base balance. Since the high prevalence of diabetes ensures that clinicians in virtually every medical specialty will interact with these patients, familiarity with related electrolyte abnormalities is important.